So Dr. Chunn, Dr. Goeke, thank you for joining us today. We at MedAxiom are excited to have you here to talk about your breakout session around the utilization of APPs. And I want to thank you for that presentation and for the time to talk a little bit more about some of the material that you talked about during your breakout session. So the first question that I have for you is, can you tell me about how you're utilizing APPs within your own practices?
Sure. Well, we're utilizing APPs both in the hospital and in the clinic. Years ago, when we first started, we used them pretty exclusively in the hospital. Then we developed a heart failure clinic, and we really limited it to the heart failure clinic in the hospital for a good while. And we sort of noticed that we were becoming a practice that was seeing really a lot of established patients and not enough new patients. And we had to figure out a way, because our practice had grown so much over the years, a way to bring in more new patients. And so we decided to bring in MedAxiom, and Ginger came in from MedAxiom as a consultant and worked with us to help us look at a way that we could fast track movement into having more APPs in the clinic. And so she came in, did analysis, and we moved toward more and more and hired some, and we were able to actually increase the amount of new patients from 9% to about 15%. Our goal is to have 20% new patients and 80% established. And so APPs in the clinics enable us to do that. So we use them in both places.
Excellent.
And we're very similar. For years, we had been primarily just utilizing them in the hospital setting. We had a large growth in APP volume over the last couple of years to both build out our outpatient clinics, just the general clinics, to leverage physicians since we have a big backlog. We actually committed, like you, to new patients. We actually block 25% of our physician slots for new patients, and so that has created a domino effect of existing patients not being able to get in. And so we're building pods where we have a limited number of doctors associated with a limited number of APPs to try to leverage those doctors to be able to get better access for patients.
Good. And it sounds like you're both using APPs in a hospital setting as well as in a clinic setting. Are you splitting their time? So in the morning I might work in an office, and in the afternoon I'm working in the hospital. Or are they dedicated to one specific site each day? How is that working within your practices?
Ours is that we have some that work both places, some that are more heavily in the clinic and some more heavily in the hospital. So it's kind of a combination. We found that the higher volume APPs in the clinic, it's better to develop those and to try to keep them primarily in the clinic, because they're more efficient by doing that. The bouncing back and forth can be effective and is effective with some of the APPs, but we have sort of a combination.
Right.
So on any given day, they're working in one setting or another, either in the hospital. We're very rotational based in our practice. We actually hired 17 APPs in about 18 months, and so in that process, a lot of them were new. It required a lot of training, and so we had some growing pains where we had people that were just doing hospital, some that were just doing office, and we had a lot of burnout with that. It was a very heavy, do 10 hours of clinic 4 days in a row was very hard. And so we've actually transitioned where all of our APPs are now doing some time in the hospital and some in the office. And we think there's several advantages to that. One, when they're in the hospital, oftentimes they'll follow up that patient that they're discharging in the clinic in a week or two. So it improves, it's easier for them, and there's some continuity there. And two, when we had APPs that were just in the hospital, they lose kind of the perspective of how important it is to do the details in the discharge summary. So now that they're on the clinic side and they see this patient that was just in the hospital, and I think their discharge summaries are becoming more detailed, more valuable, because they realize how important that is for bridging that inpatient-outpatient gap. And so not everybody's the same percentage of time inpatient, outpatient, but everybody's doing some of each.
Excellent. And one other thing I was wondering about is, how do you measure, or what outcomes are you using to see that your APPs are being used effectively within your practices?
I think long term we'll look at things in the quality arena, in the patient satisfaction arena. The initial outcomes for us were to expand our new patient capabilities, to be able to take patients into the practice sooner without having to wait as a new patient, and then also secondarily to expand the established patients, but to shift some of the established patient follow-up visits from the physicians to the APPs in order to free up slots and decrease the wait of people waiting to get in to see that are new patients to see the practice. But I think, again, long term, our hope would be that we'll emphasize the patient satisfaction as well with the APPs as well as the rest of the practice. So.
Good.
We do track very closely their slot utilization as a measure of you know, how well we're filling them, and then as feedback to the physicians that and trying to track the physicians' follow-up percentage, and hopefully that's going down as the APP follow-up percentage is going up. Initially, when we added a lot of APPs in the clinic, it created another problem where they had all this availability and we were giving direction to the schedulers to fill these folks, right? And so we changed, all of the hospital follow-up came to them, but they started getting all these sick reevals, and we had all these new APPs that were really a bit shell-shocked by that. So we've had to do a little bit of reconfiguring where we you know, are trying to free up some doctor time for the sick reevals so that the APPs are getting more of the routine follow-up. But using that slot utilization is a little bit of a mixed blessing, but it is helping us now that we kind of have it a little right-sized to figure out, you know, do we need as many APPs in this office, or should we shift them if the, you know, the utilization is a lot higher in one area than another? And then I think, like you, will transition to trying to track patient satisfaction and that type of thing as we get the plan a little bit more developed.
Great. And finally, I'm curious to know your thoughts around the governance structure that's important to have an effective APP program. What structure do you have, and maybe some of the barriers that you encountered in putting that structure in place?
I think one of the things we looked at that it was a challenge for us, an ongoing sort of challenge, is that we had a real informal structure. And once MedAxiom came in and helped us with expanding our clinical APPs, another part of it was looking at governance and trying to establish a more formal leadership structure, which the recommendations were great. And we were able to really designate a lead APP with some supervisory APPs in different locations and different subspecialty APPs, as well as trying to tie down a more physician champion to work with the APPs. We had basically by location different doctors telling APPs different ways to do things, and what we needed to do was to standardize that, to put in place protocols and to basically establish a more formal structure, which we were able to accomplish in a pretty short period of time, and it's been phenomenal. We now have a much more organized onboarding process as well as an orientation program that's more formalized, and it's helped us tremendously as far as getting structure in there.
Great.
We've always had an APP manager that was an APP. Our initial one that was the lead for a decade then became the chief nursing officer of the whole health system. And we weren't really prepared to have, there wasn't a chain of replacement. And so someone stepped up and really didn't have the leadership and skills. And thankfully, we have an APP manager now that's 50% clinical in the heart failure transplant, and then 50% administrative. And it is amazing how important having a good quality leader over that, because there's a lot of issues with you know, a group of 39 APPs. You know, the hourly worker versus the professional mentality and balancing all of that. And so we had Ginger came in and worked with us, and we've had involvement with the EAP and the hospital just to really improve the professionalism. So we have an APP manager, and then each of the subspecialties has kind of a clinical lead to kind of be the overall mentor, but very clear that there is one ultimate APP manager and leader.
Great. And I think that governance structure is so key to having a successful program with your APP. So Dr. Chunn, Dr. Goeke, thank you for meeting with me today. Thank you for leading the way with how you're utilizing your APPs. It makes me very excited to see programs that are really out there doing it right. So thank you for that, and thank you for your presentation as well. So we appreciate your time.
Sure, glad to be here.
Thank you.